Sandra Aleksic. I am an endocrinologist and assistant professor of medicine in the divisions of endocrinology and geriatrics at the Albert Einstein College of Medicine in the Bronx, New York. My clinical interest is in treating older adults with endocrine diseases, and I'm also an aging researcher focused on the interactions between age-related hormone changes and age-related declines in function. Hormone levels do show very marked changes with aging, and this does differ a little bit from one hormone axis to another. Probably the most dramatic and obvious changes are changes in sex hormones in women. Around age of 50, women experience abrupt decline in ovarian function that leads ultimately to cessation of ovulation and menstruation, what we call menopause. At the same time, men tend to experience some decline in testosterone levels, but these seem to be more gradual and more related to the health condition of a man. Specifically, we have described that men who are very healthy and who reach longevity tend to have preserved testosterone levels for a while. Some of the other changes that are quite dramatic are changes in the growth hormone and insulin-like growth factor 1 levels. We know that growth hormone is hormone that's necessary for growth and development. Thus, it makes sense that the highest amounts of this hormone are secreted during childhood and adolescence. And really, once we enter our early 20s, there's quite a bit of reduction in secretion of growth hormone. And we can detect this by either measuring growth hormone levels or the levels of the hormone that is produced under the influence of growth hormone in the liver, which is called insulin-like growth factor, or IGF-1. In addition to these changes in sex hormones and growth hormone, there are also some more subtle changes in the thyroid function. It appears that older adults develop a state of slight hypothyroidism or reduced thyroid function, and we do have some evidence to believe that this actually might be a protective adaptation to aging. Another thing that occurs in older adults is that there's actually an increased production of antidiuretic hormone, or ADH, and older adults also seem to have greater sensitivity to this hormone. So one more axis that's affected is hypothalamic pituitary adrenal axis, specifically production of cortisol. While there is no reduction in the amount of cortisol that's being produced in the body, there is actually change in the timing and the normal cycle during the day of how cortisol is produced. In younger people, cortisol levels are very high in the morning and then they dip very low at night. In older adults, that dip at night doesn't happen quite a bit, so they do tend to make more cortisol at night. And also the whole rhythm of cortisol secretion is moved by a couple of hours towards earlier time. So overall, there's quite a bit of changes, and some of them are considered to maybe contribute to some of the functional decline that we see in aging, but others are also thought to be, at least in some aspects, protective. These naturally occurring changes in hormone secretion and hormone levels with aging do have implications for how we treat older adults with deficits of pituitary hormones or hypopituitarism. Before I get to how these changes are managed, I do want to briefly also touch upon the changes in presentation of older adults with hypopituitarism. Specifically, older adults tend to present with more milder symptoms, and frequently it takes a little bit longer for physicians to diagnose that they have decline in pituitary hormones. Part of the reason for this is that many of the symptoms of lower levels of pituitary hormones are seen also in aging, such as loss of energy or redistribution of body fat, fatigue, and also some of the hallmarks of abnormalities in pituitary hormones that we see in younger people, such as abnormal menstrual cycles in women or impotence in men, are not seen anymore in older people. So there is a difference in presentation that we need to think about. Also, when an older person sees their physician to be diagnosed for hypopituitarism, the physician gets into this situation where they have to really consider age-appropriate limits for hormones, hormone levels in their diagnostic workup, as well as many other factors, such as existing diseases that a person might have that could affect levels of these hormones, both acute and chronic diseases, as well as medications that they take. And older adults frequently take a number of medications that can interfere with normal functioning of hormonal axis and make the diagnosis of these conditions challenging. Now, coming to how we think about replacing hormones in older adults with hypopituitarism, we need to keep in mind both natural changes that occur with hormones and also the effects of, for instance, medications that person might be taking, which will affect both how quickly these hormones are eliminated from the body, or as we call it, the clearance of the hormones, but also the effect of these hormones. So for instance, if we talk about adrenal insufficiency, while there are no clear official guidelines on how glucocorticoids should be replaced in older adults with adrenal insufficiency, the expert opinion is to use lower doses than in younger people. The reason for this is that in older people, whatever hydrocortisone, for instance, that person takes seems to hang around longer in the body, so it's cleared more slowly. Therefore, they need less of the hydrocortisone. So we really want to aim for the lowest possible dose of glucocorticoids that will maintain good energy levels, but at the same time reduce the risk of comorbidities that are associated with giving too much of these hormones, such as increase in blood pressure, blood sugar, and so on. When it comes to other hormones, for instance, for the thyroid hormone replacement, we also recommend to start with a lower dose than in younger people, and then to increase the dose slowly. There's also some evidence that the total dose that an older person needs is actually lower than the total dose that the younger person needs. And part of this is because there is, again, a slower clearance of the thyroid hormones. So whatever amount of the thyroid hormone older person gets tend to stay in their body longer. In addition to this, in older people, we worry more about side effects of giving them too much thyroid hormones because they are at higher risk for some of the negative consequences, such as osteoporosis, heart arrhythmias, heart failure, and so on. Overall, if we are looking what kind of level of thyroid hormone we want to achieve in older adults, we are aiming for lower levels than in younger people. Now, coming back to some other hormones, one of the hormones that is commonly replaced, but is still debatable depending on the physician, is the growth hormone. So there is no clear one-size-fits-all guidance whether someone who is older should continue to receive growth hormone replacement, knowing that there is this pretty steep natural decline in growth hormone levels with aging. But some experts would recommend replacing it as long as person is not older than 80 years and don't have contraindications. One contraindication, or meaning the condition where growth hormone should not be given, is an active cancer. In this case, also, if older person is receiving growth hormone, they should receive a lower dose than younger person, and there should be a careful monitoring of the possible side effects, which again may include rise in blood pressure, rise in blood sugar, swelling, carpal tunnel syndrome, and so on. Coming to sex hormones, in older women who have hypopituitarism, we generally follow the same guidelines as in other menopausal women, which means that while we do recommend hormone replacement therapy in women with hypopituitarism until they reach about menopause age, after the age of menopause, which is on the average around 50, 51 years, we don't necessarily want to continue that replacement, and we might consider tapering the dose down really to the level that controls hot flashes if the woman has them. In terms of older men who need a testosterone replacement, this is something that we can continue for life. So this is a little bit different than in women, where, in women, we tend to taper these hormones and discontinue them as they go beyond menopause time. But in older men, we can really continue these hormones for life, albeit at the lower dose and in general targeting lower levels than in younger men. One more hormone I would like to mention is arginine vasopressin, or DDAVP. So older adults tend to have greater sensitivity to this hormone, meaning that they will retain more water in their body as a result of receiving arginine vasopressin. For this reason, we do recommend going with the lowest possible dose that will control the symptoms and maintain normal sodium levels. When we talk about controlling symptoms, we might not reach the same level of control as in younger people. For instance, younger people don't typically, unless they have AVP deficiency, will not typically get up multiple times per night to urinate, while in older people, this just might be part of the aging of the genitourinary system, and we cannot just aim for no getting up at night at all. So we need to be realistic and reasonable with our goals, but also very careful not to overtreat an older adult. So overall rule is that across these different hormonal axes, we tend to treat older hypopituitary adults with lower doses and more careful monitoring of side effects. One consideration that I would like to highlight for both the patients with hypopituitarism and the physicians who are taking care of them is that the changes will happen as these patients age, meaning that even if someone was used to being on the same amount of hormones for many years, for instance, if they developed hypopituitarism at younger age or middle age, there should be flexibility in adjusting these hormonal regimens as people age for all the reasons that were previously mentioned. So if you're a patient with hypopituitarism and your endocrinologist suggests maybe reducing your dose of hydrocortisone or your dose of testosterone or your dose of levothyroxine, this is something to definitely consider, and not necessarily think that things will always stay the same because our needs for hormones do change as we age. One new study that I would mention is the TRAVERSE study. So this was a long anticipated study which was designed to investigate cardiovascular safety of testosterone replacement. And one disclaimer here is that most that we know about replacing testosterone in older men comes from populations that are not pituitary patients. Unfortunately, we have very little data about specifics in terms of the dosing and the mode of replacement and outcomes of replacement of testosterone in older adults with pituitary disorders. So we frequently have to extrapolate from non-pituitary disease populations to inform our treatment decisions in these patients. TRAVERSE in particular was a study that was recently completed that specifically involved middle-aged and older men who had a high cardiovascular risk, and then randomized them to receive either transdermal testosterone gel or placebo, and followed them for several years to establish any difference in cardiovascular events. What's very reassuring is that this study did not show increased risk of cardiovascular events. with testosterone therapy in these patients who are very high risk for heart disease. So that's really reassuring. But also some of the caveats to consider is that we are not sure if we would get the same results for a different mode of testosterone application, for instance, testosterone injections. And in general, in older adults, we should probably consider more frequently using transdermal testosterone applications, such as with gel, because these kind of preparations would give us more stable levels of testosterone and with less very high peak concentrations, which could potentially be dangerous. The study did identify some risks that we need to keep in mind when we treat older men with testosterone. For instance, it confirmed high risk for blood clots, high risk for prostate enlargement, high risk for blood levels, meaning hematocrit and hemoglobin going high, as well as some of the new risks that were not necessarily appreciated before and need to be investigated more, specifically risk of acute kidney injury and a type of heart arrhythmia called atrial fibrillation. So overall, I would say that, if an older person with hypopituitarism, older man with hypopituitarism is considering testosterone replacement, the results of this study are encouraging in terms of the cardiovascular risk, but within the limits of using preferably transdermal gel to replace testosterone, and also aiming for the levels that are for sure below the middle part of the reference range for younger people. Another study I would like to highlight is an observational study that was published in 2023 that actually covered the largest registry of individuals with Cushing's syndrome, which is a European-based registry called ERCU-SYN. So this study specifically focused on the characteristics of older adults within this registry, and they defined individuals 65 and older as older adults for the purpose of this study. So first they found that out of about 1,800 of individuals with Cushing's syndrome, about 10% were older, 65 and older. Most of them, about 70%, did have pituitary-dependent Cushing's syndrome, or what we call Cushing's disease, that results from pituitary tumor, which is secreting too much of the ACTH and then stimulating adrenals to produce too much cortisol. This study highlighted some differences in presentations of these patients. For instance, if we look at people who are younger than 65, this disease is predominantly female. Almost 3/4 of all people who present with the disease are female. However, in those who are 65 and older, it's more half and half situation. So about half are female, half are men. Then another thing that's very common in younger adults with Cushing's syndrome is overweight and obesity, with average BMI approaching 30. While in older adults, on the average, actually, they did not have either overweight or obesity. Older adults were also more commonly presenting with muscle weakness, with skin symptoms that are more typical of aging, such as skin atrophy or thinner skin, but less skin symptoms that you would think about when you talk about Cushing's disease, such as purple stretch marks. And also, they were less likely to report symptoms such as depression and loss of libido, which seems to be related to a general trend in older adults to be less likely to report these symptoms. Interestingly, even though there was no appreciable delay in diagnosis, older individuals did present with a larger adenomas, so larger pituitary tumors than younger individuals for unknown reasons. It's unclear if they have somehow different biology of these adenomas, or there's something else that's at play here. It also seems to be quite different how physicians manage younger versus older adults with Cushing's syndrome. For instance, while in younger individuals, meaning individuals less than 65 years old, majority had at least one pituitary surgery. About 70% had at least one pituitary surgery. This was less common in older adults. And if they did have pituitary surgery, it was usually not the first line. The first line was quite frequently medical therapy or radiotherapy, which might be due to a combination of factors. And obviously, this is an observational study, so they could not necessarily understand fully why these different decisions have been made. But we do know that older adults in general have higher perioperative risk. And weighing risk of surgery with the benefits of potential cure of Cushing's syndrome and Cushing's disease is probably something that their physicians took into account. It's quite possible that frequently comorbidities that are associated with both aging and Cushing's disease, including diabetes, cardiovascular disease, might have precluded referring some of these individuals for therapy, and their physicians have chosen more of a conservative approach. Among people who did have what was considered successful transsphenoidal pituitary surgery, there seems to be quite a good remission rate in both older and younger, but still the rates are somewhat lower in older individuals, where about 50% of individuals who are deemed to have had successful transsphenoidal pituitary surgery would remain in remission starting several years after the surgery. And those numbers were probably closer to 60 to 70% in younger people. That is a very good question. And really the overarching theme is that many of the pituitary disorders seem to accelerate what we see with aging, meaning that people tend to get sooner and maybe more significant aging-related diseases, such as cardiovascular disease, cancers, also functional decline, frailty, and so on. There is some specificity to this depending on the type of the pituitary disorder. So I will cover several of them separately. So for instance, when we talk about Cushing's syndrome, we know that first, if we look at all patients with Cushing's syndrome, about 9 to 10% of them will be 65 and older when they're diagnosed. So it's not so common to have older patients with Cushing's syndrome who is first time diagnosed, but we do tend to see this. And they tend to present with somewhat different symptoms than younger people. So they will more likely have diseases of aging, such as cardiovascular disease, diabetes, high blood pressure, and they're less likely to complain about loss of libido, depression. They're also less likely to have some typical skin changes, such as striae or increased hairiness, but more likely to have thinning of the skin or skin atrophy. So overall, some of these types of symptoms do tend to overlap with aging. Another symptom or sign that's quite present both in aging and specifically in patients with Cushing's syndrome is loss of muscle mass. And older adults with Cushing's syndrome seem to present with more muscle loss than their younger counterparts. So really, when we talk about managing these risks in older adults, we need to be mindful that they do have higher risk of cardiovascular disease. They have high risk of osteoporosis, of muscle loss. And really, the treatment should be directed both at controlling the disease, in this case, Cushing's disease, but also at managing all of these risk factors, which means that, for instance, if we talk about reducing cardiovascular risk, we really need to stress the importance of exercise, healthy diet, but also medications to reduce levels of cholesterol, levels of blood pressure, levels of blood sugar. If we talk about preventing fractures, which are quite common in older adults with Cushing's disease, according to some studies, 1 in 4 presents with fractures. We really want to make sure that we provide adequate therapy, support with vitamin D and calcium, and then anti-resorptive therapy as needed. When we talk about some other conditions, such as acromegaly, for instance, we also have some differences, first in clinical presentation. And again, a lot of the presentation may overlap with what we see in aging. The general theme seems to be that older adults who have acromegaly tend to have more diabetes, more hypertension, more heart enlargement than their younger counterparts. And then also they have more sleep apnea. In terms of joint complaints, there's really not such a great data. They do present more frequently with joint complaints comparing to the younger people with acromegaly. However, we don't have a good data that can confirm that older adults with acromegaly have higher prevalence of osteoarthritis comparing to general aging population. Another presentation of acromegaly, which is also seen in aging, especially in women, are vertebral fractures. So we know that as women age and enter menopause, they tend to develop bone loss, and this increases risk for fractures, including vertebral fractures or fractures in the spine. We know that older adults do have these fractures, but we don't know for sure if older adults with acromegaly tend to have more vertebral fractures than their younger counterparts. When it comes to some other geriatric specific syndromes, such as syndrome of frailty or cognitive decline, there is some data to suggest that older individuals with acromegaly seem to have more frailty and greater cognitive decline comparing to older adults without acromegaly. But again, this area is understudied and we definitely need more data. First, we are seeing more and more older adults with pituitary conditions, and this is a combination of the fact that we are getting better at treating these disorders and people are living longer with them, and also of the fact that we are doing more diagnostic studies, for instance, brain MRIs that then find incidental pituitary tumors, and through workup, we identify some hormonal secretion or hormonal deficits from these tumors. So overall, there is an increased number of older adults with pituitary disorders. And what's interesting is that because we've got better in treating them, they tend to have very similar risks as the general aging population, which means that really when we talk about managing their health, we want to focus on the all those interventions that we would use to promote individuals' health in aging in general. Obviously, in addition to treating the main disease, if there is hormone oversecretion, such as in Cushing's or acromegaly, we do want to target those diseases. And in addition to those adjustments to hormonal replacement strategies that I discussed earlier, in all older adults, we really want to focus on optimizing their physical function and reducing their risk of chronic disease. And really, when we talk about optimizing physical function, the most important part of this is exercise. We all tend to get more sedentary as we age, which is truly detrimental for our health. As people age, they tend to lose their muscle mass, and it also gets harder to build the muscle mass. This is additionally difficult in individuals with pituitary diseases. For instance, individuals with Cushing's syndrome who tend to lose muscle more rapidly due to cortisol effects. So really, exercise, which any exercise is better than no exercise, but ideally should be a combination of aerobic, resistance, balance, and flexibility, is something that has been shown very reliably to prolong life and improve health. In addition to exercise, we really want to be aggressive about reducing cardiovascular disease by other strategies, which will include obviously healthy diet and maintaining healthy body weight, but also using the medications to control the risks. The truth is that people with pituitary disorders, like the general population, have the highest chance of dying from cardiovascular disease. This is still the #1 killer. in older adults, and we want to be very aggressive in treating those risks, including lowering cholesterol, lowering blood pressure, controlling diabetes, and so on. Obviously, a very important part of the overall wellness is stress management and social connection. We know that people who are able to better manage stress and have more meaningful social connections have healthier aging. This is also very protective for the brain health, which is obviously something we want to protect as we age. And sleep. Sleep is very important. Sleep is important for your mood. It's important for your brain health. It's important for your metabolic and cardiovascular health. So really, I think that what is very important message here is that in addition to treating whatever pituitary condition individual might have, we should not forget this holistic approach to an aging individual, which really should focus on multiple prongs, including exercise, diet, medications to reduce risk factors, and then their emotional health.